Hi, I'm Dr. Kawita Bapat. Today's topic is assisted vaginal deliveries. Learn simply for the undergraduates, graduates, and practicing OBGYN. The objectives of this topic is that first is the classification, what are the indications and contraindications, what is the used when the ventouse is preferred over the forceps or the vice versa, what are the prerequisites for the assisted vaginal deliveries, how to make decisions, what are the complications, what are the sequential instrumentation, and how impacted head works. Now, the art of the forceps prior to the assisted vaginal birth, it is imperative to achieve the level of experience. And the proficiency at it is potentially harmful in the hands of inexperienced and imprudent obstetricians. So it's very, very important to know about. And we can divide into two classes. First is the ventouse and another is the forceps. The classification is like this. There's the outlet, low and mid. What is outlet? When the fetal scalp visible without separating the labia, fetal skull has reached the perineum, rotation does not exceed 45 degrees. Then the low assisted vaginal births, the fetal skull is at the station of plus 2 centimeter, but not on the perineum. There are two subdivisions. Number one is non-rotational, less than 45 degree, and second is the rotational, that's a more than 45 degree. Then the mid is the fetal is not more than 1/5 palpable per abdomen, and leading point of the skull is the station is 0 or plus 1 centimeter. Against two subdivisions, non-rotational is less than 45 degree and rotational is more than 45 degree. Now, what is the outlet forceps? Outlet forceps, for example, the Wrigley's forceps are the small used to lift out the deliveries and add cesarean sections also. Outlet forceps are used when, number one, fetal scalp is visible without separating the labia. The fetal skull has reached the perineum and rotation does not exceed 45 degree. Low forceps are used when the fetal skull is plus 2 centimeter, but not on the perineum, non-rotational, less than or equal to 45 degree, and rotation is more than 45 degree. Now, the mid-cavity forceps are used when the fetal head is 1/5 palpable per abdomen and the leading point of the skull is situation at 0 or plus 1 centimeter and not above the ischial spine. And rotation is more than 45 degree and non-rotational is less than 45 degree or equal to 45 degree. Now, the indications for the assisted vaginal birth, we can divide it into the fetal and a maternal. Fetal is a sometimes suspected fetal compromise like a cardiotrophy pathological, sometimes abnormal fetal sampling, thick meconium, and then the maternal causes, nulliparous women, lack of continuous progress for 3 hours, total of active and passive stage of the labor with the regional anesthesia or 2 hours without regional analgesia. In Paris women, lack of continuing progress for 2 hours, it may be total active and passive second stage of labor with or without the regional analgesia. Then the maternal exhaustion and distress and a medical indications to avoid Valsalva manure. So the combined fetal and maternal indication for the assisted vaginal birth often exist. Now the indications are again similar. The presumed fetal compromise, most common indicator prolonged second stage, and it contributes 14 to 20% of the overall AVB. Now the maternal indication, exhaustion, cardiac, pulmonary, and neurological. Contraindication is, number one, contraindication is operator's inexperience, incompletely dilated cervix, unknown fetal position, and unengaged head. Another contraindications are malpresentation, brow and face or like that, suspected CPD or cephalopolypic disproportion, ventouse delivery gestation is less than 36 weeks, it's like that. Now, below 36 weeks, preterm and ventouse, cephalohematoma, intracranial hemorrhage, there's a subgaleal hemorrhage and a neonatal jaundice. There is insufficient evidence to establish the safety of vacuum extractors and the gestation between 34 weeks to 36 weeks. Relative contraindication, baby has predisposition for fracture. So the osteogenesis imperfecta, baby diagnosed with, has a suspected bleeding disorder such as hemophilia or this is all immune thrombocytopenia. And the hepatitis B, HIV carry risk of vertical transmission, prior repeated fetal sampling done, which has already caused abrasions. Now, the conditions where forceps would be preferred to ventouse are poor maternal effort, operator or the maternal preference, when either instrument would be suitable, large amount of caput, marked active bleeding from the fetal sampling site. And these others are again the similar one, the sampling site. The other conditions are gestation is less than 34 weeks, is relatively ventouse is a contraindicated, and after coming head of a breech and a fresh presentation. Assessing the mother and fetus is very, very important. Prerequisites for the artificial vaginal, the assisted vaginal birth are: number one is anatomy of the pelvis and the fetal head, and one should be very, very skilled on doing this. The goal of assisted vaginal birth is to mimic spontaneous vaginal birth, thereby expeding delivery with minimum or maternal neonatal morbidity. So these are the safety criteria: the preparation of the mother, preparation of the staff, and a vaginal examination. These are the FORC. This is F is full dilatation. O is palpable, only 1/5 palpable abdominally. R is a ruptured membrane. And C is a contractions adequate. Another prerequisite is a consent, then the empty bladder, and the presentation and a position known. S is station, S is satisfactory analgesia. So ABCDEFGHI of this is: A is address the patient, analgesia abdominal examination. Number 2, bladder is empty. C, cervix is fully dilated. D, determine the position and think and prepare about the shoulder dystocia. E, explain to women an exit plan if it fails and ready for cesarean section and check equipments. F, frontanalise to check position. G, a gentle traction. H, hold between the contractions and hold the procedure if ventouse suction disengages 3 times and there is a no progress with 3 pulls. Then I is incision and episiotomy, and J, remove instruments when jaw visible. Passage of the head. It can be inlet cavity or outlet, transverse oblique and anterior posterior position. We should know about this, and this should be assessed. Now what is the decision making? Most appropriate instrument is needed, safest location, when to abandon the instrumental delivery. So this is the flow chart. Check the fetal condition. If referring, prepare for delivery. Yes, are the contractions adequate? If yeah, is the mother pushing effectively? Is the delivery of the head being arrested by the perineum? Bladder empty? Position of the station and the fetal head favorable? If all are yes, then all is considered according to the parental preference. If there is no, consider oxytocin, consider changing maternal position, and so many things. Decision points in the considering the instrumental delivery: assessment, anticipate and encourage operative delivery, instrumental delivery or cesarean section, low cavity, non-rotational, aim to delivery labor room, attempt mid cavity or delivery, choice of ventouse, venue and choice of instruments. Now reducing the assisted vaginal birth rate ensures a really necessary 1-to-1 support in a labor, upright lateral positions, avoidance of epidural analgesia. Again, we can reduce the birth rate by assisted vaginal birth rate by use of partograms. Consider oxytocin for inadequate contractions, prolonged second stage and epidural analgesia, delayed pushing in a women with epidurals. Now, the choice of instrument determined by the instrument most appropriate to the clinical circumstances, operators' levels of skill and rationals. This is a rotational delivery should only be performed by experienced operator and not associated with a higher risk of maternal morbidity than cesarean section when they are used by appropriate trained personnel. So the choice of instrument, again, the rotational deliveries, rotational ventouse, metal cap, kiwi or all sort of it, then the manual rotation and forceps. Heel and forceps is also a choice, but when choosing the instruments in elective situation, operator should weigh upon the following factors. Number 1 is the analgesia for the mother. Number 2, uterine cavity. Number 3 is the maternal effort, very important. Number 4 is the fetal position. Number 5 is the degree of fetal scalp molding and a caput. And last is the significant fetal factors such as a gestational age. The rule of 3S, one should consider in the occipital anterior position, the fifth of the fetal head palpable above the pelvic rim is added to the degree of molding to give the indication to the outcome of the instrumental delivery. Forceps delivery is unlikely to be succeeded if the total is more than equal or 3. Now, this is the rule of 3 again, the 3/5 above the pubic symphysis. These are and the 2/5 pubic symphysis. The mid cavity, select the maternal rotation, select Keelands if presence of dense regional block, descent of fetal head, the birth, absence of the sign of true CPD. Now the risk and the benefits. Ventouse benefits, less trauma to the maternal pelvic floor. Risk, more likely to fail sequential use of instrument, cephal hematoma and retinal hemorrhage. Forceps, more likely to be successful, pelvic floor injury, temporary altered fecal continence. And these are the locations which we can see into doing and when to consider a cesarean section. This is a chart, depends upon the position, station, molding, caput, descent, ease to rotation of the fetal head, birth canal, and fetal status. So unable to define position, risk of failing and causing significant fetal trauma, or head above the spines, or excessive caput and molding, think of CPD. And instrumental delivery should not be attempted. Higher rate of failure rate with maternal body index mass is more than 30, estimated fetal over 4 kg, short stature, head circumference above 95th percentile, occipito-posterior position, and mid-pelvic cavity 1/5 head and a palpable per abdomen. Then the communication and teamwork is the thing which is very, very important. Assisted vaginal birth should be seen as a team effort. It should not be like a one person's job. It should be a good communication between the obstetrician, midwives, nurse, neonatologist, and importantly, the anesthetist. What type of consent women should inform about in the antenatal period, verbal consent for the deliveries in the delivery room, rightly documented the notes, written consents for the trial of assisted vaginal birth in the theatre, and delivery of the head. The head should be delivered in a controlled and a slow manner, reproducing the mechanism of normal birth, and should be achieved within 3 to 4 contractions. And descent should be achieved with each contraction. Now the pair, this is when should AVB be abandoned? No evidence of progressive descent with each pull. Delivery not imminent following 3 pulls with a correctly applied instrument with an experienced operator. So the benefits of AFB is compared with the cesarean section at FD includes reduced complication rate, reduced analgesic equipments, shorter hospital stay, quicker recovery, increased likelihood of spontaneous vaginal delivery with the next pregnancies, more than 80%. So the maternal complications, it can be so many complications, can be episiotomy problems significantly, then postpartum hemorrhage. Sometimes there is a bowel and urinary incontinence, common in 6 weeks, improves over time. Now, the occipito-posterior position was associated with a 4-fold increase in the risk of anal sphincter injury compared with the occiput anterior position, which persisted after controlling the multiple covariables. Now, the perinatal outcome also, the troublesome, can be hematomas, there can be a scalp laceration, retinal hemorrhage, jaundice, subgaleal hemorrhage, intracranial hemorrhage, cervical spine injury, skull fracture, facial nerve palsy, fetal death, very rare. So the wrong application can lead to facial nerve palsy, subconjunctival hemorrhage, and so many things. So brain damage also causing by the forceps should be. Why do problems occur? Problems ahead, caution safety first. Failure in identifying the position of fetal vortex, maternal fetal risk factors, inadequate practice is the ultimate point, and not willing to abandon the position. It's go on continuing doing the procedures. If it is not needed, still is a big problem. And if there is no descent after the multiple pulls. Aftercare is a thromboprophylaxis, analgesia, bladder care is important, debriefing, indications for AFB, management of any complication, prognosis of future delivery, psychological. Sequential use of vacuum and forceps, we can use the both. Then the instrument, the vacuum, then forceps to complete the delivery, very controversial. There are many clinicians who would argue that such events should never occur, but significant of group would prefer to defend the sequential use of vacuum and forceps in certain circumstances. Sequential instruments, again, the use of sequential instruments, especially ventouse followed by forceps, has been associated with severe scalp trauma, intracranial hemorrhage, neonatal death. Second stage cesarean section also requires expertise. Then again, sequential instrument used in associated with significant increased risk of intracranial hemorrhage, seizures, facial nerve palsy, depressed Apgar score, laceration, postpartum hemorrhage. Then second stage LSCS, consider if a head high, position not known, excessive caput, and the appropriately experienced operator. So many things with the sequential, this thing is a failed vacuum, use of this is not good, but there is must be balanced against the risk of potentially complex cesarean section. Now, the double setup, no evidence of increased maternal and neonatal morbidity following trial of AFB and compared with. However, delay associated with a transfer may be negative impact on neonatal and target 15 minutes for delivery in liver ward and 30-minute delivery in the theatre. Now, these are the differences of the trial forceps and a failed forceps. These are the problem. Knowing a certain degree of disproportion mid-pelvis may take a procedure incompatible, should be done only in OT. Then the failed problems when the vigorous but unsuccessful attempt is made of the forceps, anticipating a successful delivery. And there are problems due to CPD, malposition, or incomplete cervical dilatation. Now, the essential conditions for the safe are assisted vaginal birth. Operators should be confident and competent, understand the anatomy of the birth canal and the fetal head, experience in doing these procedures, clinical and technical skill, knowledge and expertise to manage the complication. Now, the conclusion: when the urgent delivery is required, assisted vaginal birth is possible. The clinician should opt the instrument when they feel they are most skilled and using the ensure safe and successful delivery. Thank you so much for the patient listening. Assisted vaginal birth is a really important topic, and we should consider ventouse and forceps if you are skilled and able to do the things. Thank you so much. Recording हुई होगी क्या?